Welcome, everyone. Thank you for joining us today at Social Participation Works, engaging those left behind to drive universal health coverage. I would like to let you know that French and Spanish language simultaneous interpretation is available during this session. The feature has already been activated and is available by clicking the interpretation button at the bottom of your screen, where you can select the language that you would like to hear. If you do speak English, please also choose the English language channel, as we will have a speaker today who will be presenting in French. For those of you just joining us, thank you for joining Social Participation Works, engaging those left behind to drive universal health coverage. My name is Hermes, and I will be your technical facilitator today. Please use the chat function to message anyone with the title Technical Facilitator in their name for assistance. Before we get started, I would like to let you know a few features of Zoom that you can use today. If you would like to contribute a perspective, idea, or thought, please use the chat function. If you would like to ask a question, please use the Q&A button. You can find both of these features at the bottom of your Zoom window. Please note that the session today will be recorded for documentation purposes, and we are also streaming live on Facebook to enable a larger audience to take part in the discussion. You will also notice that there are live captions today at the bottom of the screen. If you would like to turn those off, feel free to do so by clicking the live interpretation button and turning off the captions. Thank you so much for your patience, everyone. I will now pass the floor to Ms. Eliana Monteforte, Director of Special Projects at the Global Health Council. Eliana, the floor is yours.
Thank you. Welcome to today's unofficial side event to mark the 74th World Health Assembly. As Hermes said, my name is Eliana Monteforte. I'm the Director for Special Projects at Global Health Council. I'm also an advisory group member for the Civil Society Engagement Mechanism of UHC 2030, also known as CSEM or CSCM. I will start our session today with an introduction and some scene setting. So today's event will focus on the importance of civil society voices and health system strengthening for UHC. CSCM and its partners truly believe that communities must be at the center of health planning and governance to ensure that all people, including those that are most at risk, marginalized, and often left behind, have access to quality healthcare without having to suffer financial hardship. Civil society is critical to connecting governments with the needs of all populations, as they are often experiencing firsthand or working with those people experiencing firsthand the problems within a health system. So currently, WHO and UHC 2030 has developed a handbook on social participation for UHC. This handbook was created jointly with civil society actors and member state representatives and provides a specific guidance to policymakers on how to effectively and meaningfully engage with populations, civil society, and communities for policy and decision-making. The handbook discusses engagement mechanism, platforms and approaches, best practices, such as direct engagement with populations, population engagement through civil society, and population engagement through communities. The handbook includes evidence from a literature review. It includes country case studies. It includes information from an external advisory group, various external advisory group meetings and internal WHO expert meetings, civil society consultations and webinars, some of which CSCM actually hosted, so you may have participated in those last year. If you are interested in learning more about this handbook, please join the launch. It's actually May 31st at 2 p.m. Central European time. I believe there's a registration link available. If somebody could drop it into the chat box, that would be excellent. Thank you. UHC 2030 and partners are also in the process of developing this year's State of the UHC Commitment Report, which provides a multi-stakeholder consolidated view of the state and progress made toward UHC at the country and global level. And the purpose of this report is to support national accountability and advocacy processes, and mostly to ensure that political leaders are held accountable for their UHC commitments. So the report will include country profiles and a synthesis report summarizing the state of UHC at both the country and the global levels. And like the development of the handbook, civil society participation is going to be extremely key to the assembly of this commitment report. In fact, CSAM and partners are currently hosting various country-level community focus groups to gather stories and perceptions and experiences and recommendations from civil society and communities on the state of universal health coverage in their countries, and also their experiences with what they know at the global level. These focus groups and the conversation we'll have today actually will serve as key information for this report and for UHC 2030, CSCM and other partners to find better ways of supporting civil society and communities in UHC advocacy, so they are more connected and involved in government health planning policy and implementation processes. If you do have any questions about the handbook on social participation, the state of the UHC commitment report, and or any of the CSCM community level focus groups, or how we plan on using today's conversation and some of the other work that I just talked about in our advocacy for more civil society engagement, I'm happy to answer those questions during the Q&A session. But having given you this context, I'm going to hand over the mic to my colleague, Khuat. She is an advisory group member of the Civil Society Engagement Mechanism. She also represents civil society for the Global South on the UHC 2030 Steering Committee, and is the executive director of the Center for Supporting Community Development Initiatives in Vietnam. So Juan, over to you.
Thank you, Eliana, and good morning, good afternoon, good evening, everyone. So I have a pleasure being the moderator for today's section. I will introduce the speaker briefly, and each of the speaker will have 5 minutes to share with you their perspective, their experience. And after that, we will have we hope to have a lot of time for our conversation with your contribution. So we will have 2 parts for your participation. One is the Q&A, the question. So if you have any question for the speaker, do type it in the Q&A. So we will collect all the questions and show it in a slide to the speaker. So we will invite the speaker to address all the questions at once. And then we will have a discussion and comment from you, from the audience. We will invite you to comment and contribute in 3 topics of the universal health coverage. One is on ensure political leadership beyond health. That is one of the asks of the UHC 2030. And the question for you is that during the COVID-19 pandemic, have government made universal health coverage a high priority? At the global level, have been any change in health and universal health coverage policy implementation before and during COVID-19 pandemic? So the first is about political leadership beyond health in relation to COVID-19. So second question, the second comment that we would like to get input from you is on leave no one behind. And the question for you is that what are the inequity in health access that have been exacerbated by the COVID-19 pandemic? And at the global level, who's addressing this issue and how? And then the third question that we would like to invite your contribution is on move together. So move together imply the partnership for universal health coverage. And the question is that, are there opportunities for people living with disease or disabilities, civil society organizations, and private sector to be engaged in planning, budgeting, monitoring, and evaluating the health sector at global level? So be ready. And if you would like to contribute, please put that in the chat box. You can say, I would like to give an intervention on political leadership or on leave no one behind. Depending on how much time left, we will try to invite you to come in panel to share your perspective. And we have only maximum 2 minutes for each person. So be prepared your intervention to be brief so that we can hear from a lot of people. Okay, so that's the hardest part of my job. And now I'll come to an easier part. Let me invite our first speaker, Dr. Pierre Yameogo, who's the Technical Secretary of Universal Health Coverage from the Ministry of Health, Burkina Faso. Dr. Pierre Yameogo will speak in French. So if you don't speak French, turn on the interpretation channel. Dr. Yameogo, the floor is yours.
OK, merci bien pour cette opportunité que vous donnez au Burkina Faso de parler de cette thématique sur la couverture sanitaire universelle. Et je vais, comme c'est 5 minutes, merci aux organisateurs, aux participants. Pour ce qui concerne le Burkina Faso, je peux dire que ces 6 dernières années, il y a des réformes qui ont été engagées dans le souci de pouvoir accélérer la mise en œuvre de la couverture sanitaire universelle. Je vais partager avec vous 2 réformes majeures sur lesquelles nous travaillons depuis un bout de temps. C'est la politique de gratuité des soins pour les femmes et les enfants de moins de 5 ans qui a commencé depuis 2016. Et c'est une politique du premier responsable du pays, c'est-à-dire du président du Burkina Faso, de faire en sorte à réduire tout ce qui est inéquité d'accès aux soins de santé pour les femmes et pour les enfants. Donc, cette mesure qui a commencé depuis 6 ans profite à toutes les femmes, à tous les enfants, et ça permet de pouvoir effectivement rendre disponibles et accessibles des soins de qualité. Le gouvernement injecte plus de 55 millions de dollars chaque année de son propre budget pour pouvoir assurer des soins à ces 2 groupes vulnérables. La deuxième réforme majeure qui va de pair avec la politique de gratuité des soins, c'est surtout la santé communautaire avec aussi le recrutement de 2 agents de santé à base communautaire par village. Et cette politique a été lancée également juste 2 mois après la gratuité des soins pour pouvoir faire en sorte que les principales causes, les principaux déterminants de la maladie, qu'on puisse adresser directement des solutions au niveau des familles, au niveau communautaire. Donc, ces agents de santé, ils sont 2 par village, au total près de 18 000 actuellement. Ils offrent des services de promotion, de prévention, et ils soignent les cas simples de paludisme, de diarrhée, de malnutrition, et également pour tout ce qui est moyens contraceptifs. Donc, c'est une mesure également qui profite à toute la population. Pour ce qui concerne également les réformes majeures, nous avons dans la mise en œuvre de ces 2 mesures contracté avec les organisations de la société civile à travers 3 ONG internationales qui sont Terre des Hommes et puis Save Children et 4 ONG nationales qui sont sur le territoire national. Ces organisations de la société civile réalisent ce que nous appelons une action de redevabilité, c'est-à-dire le contrôle pour pouvoir permettre à ce qu'on puisse savoir que les gens ont accès aux soins de santé de façon équitable et que ça profite à tout le monde. Donc, c'est vraiment une bonne pratique de contracter avec les organisations de la société civile pour pouvoir veiller à ce qu'il y ait la redevabilité et qu'on puisse réduire les cas de fraude dans les 2 mesures. Alors, pour ce qui concerne spécifiquement les soins qui sont offerts au niveau des agents de santé au niveau communautaire, ce qu'il faut noter, c'est que quand on soigne très tôt, quand on éduque les populations et quand on prévient très tôt, le coût d'investissement devient moins cher, 10 fois moins cher que quand ça arrive à un certain niveau où les soins sont plus coûteux. Donc, le défi actuellement pour ces deux réformes, nous sommes dans un contexte de COVID qui a carrément bouleversé le système de santé. Et le COVID également a mis à nu le système au niveau des hospitaliers. Donc, nous sommes en train de travailler au sein du ministère de la Santé pour un plan de mise à niveau de toutes les formations sanitaires, surtout les hôpitaux, de telle sorte à ce que il n'y ait pas une population marginalisée, surtout les populations victimes de COVID, et qui ne soient pas bien pris en charge dans ce dispositif. Le deuxième défi que nous luttons depuis encore 5 ans, c'est surtout le contexte d'insécurité et le contexte de terrorisme. Et actuellement, c'est de pouvoir offrir des soins de qualité, surtout dans les zones d'insécurité. À cet effet, les organisations de la société civile et les organisations non gouvernementales participent aux côtés du ministère, du gouvernement, à ce qu'on puisse couvrir les populations, surtout celles qui sont les populations déplacées des différents villages, et comment nous allons pouvoir couvrir les besoins essentiels en soins de santé de ces différentes populations. Nous continuons la réflexion aux côtés de la société civile pour pouvoir avoir de meilleurs résultats. Donc, en conclusion, je dirais que pour ce qui concerne la couverture santé universelle, au Burkina Faso, nous sommes sur le bon chemin avec l'implication de tous les acteurs, que ce soit les acteurs de la société civile, que ce soit les acteurs, les partenaires techniques et financiers, que ce soit le gouvernement. Nous travaillons ensemble de telle sorte à ce qu'on soit plus fort, plus efficace et surtout ne pas laisser quelqu'un de côté à travers les actions que nous réalisons. Donc voilà, en gros, ce que je peux dire en 5 minutes. Je veux espérer que je n'ai pas trop débordé sur le temps et je reste disponible pour des éventuelles clarifications. Merci.
Merci beaucoup, Dr. Pierre. Thank you very much for your intervention, which my French is terrible, but I could get just a little bit of it, and I think that many people would really appreciate to be able to understand, but unfortunately the English French translation channel is still being fixed, so I know that Dr. Pierre speaks English as well, but if you don't mind, I will now go to the next speaker, and if we can get the interpreter to summarize your remark in the chat, that would be great. Otherwise, Dr. Pierre, would you mind to go back with a summary of your intervention in English? A lot of people wish to speak French, but
okay,
we don't want to miss your, yeah, okay, great, thank you. So let me, do you want to do it now, or you want to prepare a bit? Dr. Pierre? So I will go now to Mr. Farouk and then come back to you. Is that okay for your English intervention?
Yeah, give me some few time. I try to translate into English the summary, and
great.
I will come back to you. No problem.
Okay, wonderful. So Mr. Farouk and then Dr. Pierre again. So Mr. Farouk Hwedy from Bosnia, Herzegovina, but he's a migrant from Syria. And you know that migrant and international migrant and refugee is an important group that often left behind in universal health coverage. But we have Mr. Farouk has been very actively working on the health issue of the migrant in Europe. Mr. Farouk is a member of
Yes.
the Red Cross Health Team in Bosnia. Mr. Farouk,
Yes.
the floor is yours. Yeah,
Okay.
go
Thank
ahead.
you. Hello. Good morning. Good evening. Good afternoon to everyone. First, I just want to introduce myself to you. My name is Farouk Hwedy, and I'm from Syria. Exactly from the northeast part of from Syria. It's Deir Zor, and I have 31 years old, and I'm asylum seekers or a migrants in Bosnia and Herzegovina. And I came like the other refugees to Bosnia and Herzegovina via Balkan ways, and from Turkey, I mean, and it was a long and it was a difficult road, as you know. And currently, I'm a member of the Red Cross First Aid Team, health team in Bosnia. I teach first aid, provide health and hygiene promotion. I'm directly engaged with the communities through cultural mediation and preparation of information materials in Arabic to help the other migrants with the Arab and English language. Sorry, translation. I wanted to be useful and help the other migrants, and started volunteering in Bihać and Bihać region. And then later I came to Sarajevo. I moved to Sarajevo and was engaged to work with the Red Cross with the Red Cross Federation of Bosnia and Herzegovina, and started to as a translator from Arabic to English and from English to Arabic. And I was so happy, so excited. Then later I was training in first aid and health promotion. My work is both inside and outside the camp. And about working in the camp, it's every day, it's difficult than before. And with the new people, every day we're receiving like a new people, new cases, new stories, and we try to listen to them, to understand them, what they need, what they ask. And we give them health and psychological assistant, and we engage them in planning, and we work together for every solution, as you know. And we have a small group meeting every month with the communities, migrants communities, trying to discuss different problems and teach them how to prove first aid, health education. And because we were always in the camp or in the field, the migrants right now, they believe and they trust in Red Cross, and also they trust and believe in Red Cross uniform and our emblem. And the Red Cross doesn't work on all part of the health and protection system. And when it's came to some problems and situations that are out of our work, we make referrals to our partners. We have a really good cooperation with the Danish Refugees Council, and who are doing medical examination, and that are bigger than more complicated. And if they cannot do their best, they make referrals to hospital who provide the necessary help. And for me, it was a pleasure to feel like you are helping the others. And I just want to thank all those people who empowering me and helping me to be here with the Red Cross, especially Medina Silamic and Yasmin Nikic. And in beginning empowered, make us to feel like feel as a part of something greater than ourselves, as you know, responsible for our life and health. It also gives us opportunity to connect with the people to reach for out common goals and make us feel safe and secure. Regarding the challenge during the COVID-19 pandemic, we as a humanitarian workers as well as a migrants faces a major challenge, especially with regard to our safety and security, and we do our best to secure ourselves and others by wearing gloves and protective masks and using the hands disinfection, as you know. And in additional to that, or beside that, we give everything that help in preventing the disgusting to others, to protect ourselves and protect our security. We also make sure that the other people understand our mission and trust us, as you know. And sadly, not all of our staff and volunteers have been vaccinated, and migrants are also not in the priority group for vaccination. And we also need to consider and try to provide support to local population and host communities at the same time, especially those where migrants are moving or staying, because we are trying to take care of everyone in need, not just migrants. Unfortunately, the migrants are regularly facing the complex of challenges related first of all of lack to success, to basic health services and bad sanitary conditions, not enough access to water and sanitation, food and food support, like volunteers of the Red Cross of Bosnia and Herzegovina, and doing their best to support the most as much as possible. And the government also support us too, and they recognize our role and part in the system, but many things depend on the community of the government, international partners, donors, to address the most urgent needs of the migrants. This was my speech. I will give now the microphone to the next speakers. Thanks a lot. Thank you.
Thank you, Farouk, for sharing your experience. And I think that we can, from your experience, we can see that it's on the one hand, it's the government empowerment and making the opportunity, the government of Bosnia and Herzegovina. But on the other hand, it's the community that taking the active role from migrant to helping each other, and you are a role model for that. So thank you very much. We need both sides to be able to make universal health coverage and to happen to everyone.
Exactly, that's what we mean. Thank you too. Thank you.
Thank you very much.
Thank you too.
And yeah, Dr. Pierre, are you ready to go back with us?
Yeah,
thank you.
Thank you. Just to summarize what I said in French, since 2016, government president of Burkina Faso took a major reform to reach universal health coverage. I want to share with you two major reforms in this new challenge. We have the first reform is the free healthcare policy for women and children under 5 years of age, and government approximately expenses is around 55 billion per year, and this policy allows all the women, all the children under 5 to have access of healthcare, basic healthcare, and this policy promoting equity and access to healthcare. The second major reform in the same year is the strengthening of community health, community healthcare through the recruitment of the community health workers. In each village, we have 2 community health workers per village, and it's paid by the government and partners around $35 per month, and the community health workers provide healthcare and education, promoting and monitoring the implementation of action. And to have a good access to service, we have 2 challenges. The first challenge is how to provide continuous services in the COVID context, and we have also the terrorism context with in the region. So we are now working with civil society to have well, my English, please excuse me, but I want to see that the civil society is very involving in the accountability process and the monitoring of implementation of the 2 reforms. We contract directly with an NGO and a national NGO to help us to have a accountability and monitoring of action in the government. So I think that I can stop here, and excuse me for my English.
Thank you, Dr. Pierre. Thank you very, very much. Actually, it's a beautiful summary of what you have said in French, very concise and very clear. And the 2 policy that the Burkina Faso government have implemented is just like so crucial, very essential to make sure that universal health coverage happen for community health worker, and then the coverage for all women and children under 5. I think many women would like to move to live in your country, and also a lot of NGO would like to work there. Great. Thank you very much. I think that is a great example of how the government should work on universal health coverage. Thank you again, Dr. Pierre. And now let me invite our next speaker. We have Mr. John Gikonyo, the president of Renal Patient Society of Kenya. So here we have a representative of people with disease. So John, over to you.
Thank you very much. Am I audible?
Yes, yes.
Okay, thank you, and good afternoon from Nairobi, Kenya. My name is John Gikonyo. I am the president of the Renal Patient Society of Kenya. I'm also a leader at the Caucus of Patients-led organizations at the Non-Communicable Diseases Alliance of Kenya. Kenya is one of the countries that have made a commitment to
John, we don't see you. John, we don't see you. Can you adjust your video, your camera? We don't see you. We see, yeah. We see your ceiling. Okay,
you
great.
see me now?
Yes, perfect.
Okay,
Go ahead.
Okay, now, like I was saying, Kenya is one of the countries that have made a solid commitment to attaining UHC or universal health coverage by 2030. And besides the commitment, the government has made some steps in making that a reality. The current government under President Kenyatta has set 4 areas of focus for the next course of development, what we are calling Agenda 4. And among those 4 agendas, UHC is one of them. And that shows very great commitment on the side of the government. The government has also initiated what is known as a medical equipment scheme, whereby they have procured equipments which have been distributed to the various county governments. We have 47 counties in Kenya, and each has been given equipment which enable people to access health services easily without moving out of their counties. And some of these equipment include 5 dialysis machines for each of those counties. And as you can imagine, that has really transformed the landscape of dialysis in the country. And out of that, now we have more than 200 dialysis units in the country. And this has increased dialysis access in the country to a very, very large extent since 2016, when this scheme came into place. So by and large, there is great improvement and solid commitment from the government to improve health services and to attain UHC. There have been challenges besides that, because you find that some of the changes that have been brought forward have also, brought about what I would call unintended consequences. For example, with the availability of dialysis equipment, the National Hospital Insurance Fund has also stepped in, and now they're paying for dialysis for all the patients in the country who need dialysis. And I think this is a first for the African continent. I think Kenya is the only country with a universal provision of dialysis services without out-of-pocket expense on the patients. But because the same coverage is not extended to post-transplant medication, you will find now that there's a negative effect of most patients preferring to stick on dialysis, because if they get a transplant, they will need to pay for the post-transplant medication, which is expensive, and so they prefer to stay in the safe area where there are no out-of-pocket expenses. And that's one of the areas we are urging the government and the National Health Insurance Fund, that it would be good to extend the coverage even to post-transplant medication, so that the whole the kidney patient is covered without out-of-pocket expenses, whether they are on dialysis or post-transplant. Again, there are some policies that we have found to be very good on paper, but sometimes the people who implement these policies do not seem to have the patients in mind. And when we talk about meaningful involvement of persons living with non-communicable diseases, I think the first area to start, even before you get these persons on the table, is to think about them and all the patients when policies are being made. Because sometimes when these policies are passed without having the end users in mind, they tend to hurt the intended beneficiaries of these policies. And it becomes a problem. And sometimes we've been forced to go back to the government and the Ministry of Health to highlight some areas where we have had difficulties from the policies that have been passed. I have in mind a recent policy which instructed all government institutions, health institutions, to procure from the Kenya Medical Supplies Agencies. And this is trying to consolidate and even get us cheaper drugs and equipments. But when this happened, some of the medications that we were getting from some of the government hospitals were not available at the Kenya Medical Supplies Agencies. And so the hospitals ran out of those drugs because they now couldn't buy from the traditional suppliers, but the government agency which is supposed to supply them does not have the drugs and also doesn't have a contract with the manufacturers to supply the same drugs. We were able to have a session with the ministry, and after explaining the predicament of the patients, we got a solution, and the hospital was allowed to procure from the old supplier until this situation is resolved. So there has been that dialogue between ourselves and the government where difficulties have arisen, and we see this as a good part of meaningful involvement. But what I'm trying to say is that it should come before policies are implemented, not after the pain. Also, we should always remind the government and the Ministry of Health and authorities that persons who live with non-communicable diseases and other illnesses have a wealth of user experience. And usually when we say that, a lot of people think that our user experience is only about pain and suffering, which is not the case. Some of the wealth we have is also about what works, what is working, what we should build on, and what is not working, and what should be changed. So I think when that dialogue starts happening, then we make progress because we are able to move in the same direction without having to move back to make corrections every now and then. We've had a lot of engagement with the Ministry of Health, and currently, previously, focus on non-communicable diseases has only been on the major NCDs, and that's cancer, diabetes, sickle cell, and such. So things like kidney disease have not featured anywhere, even in those conversations. But as we speak now, we have managed to get kidney disease and other rare diseases listed in the national strategic plan for NCDs for 2021-2025. And so these conversations are going on and this dialogue is continuing, and we're seeing a good improvement in that area. The COVID-19 environment has not been very kind to those of us living with non-communicable diseases and other conditions. And it has been very difficult, first of all, because of our circumstances, we have a greater risk of suffering severe illness or even death. So we have to be extra careful. And we would like to see more prioritization of people who are in our circumstances, because we bear a greater risk of getting infected with COVID-19 and getting severely ill should we get infected. And so we would like prioritization even for vaccination, which is a big challenge in the country and in the world. But we would like to add that people living with NCDs, people living with lifestyle diseases should be prioritized for vaccination so that they do not become a grim statistic in the COVID-19 pandemic. So with those few remarks, I would like to hand back to moderator. Thank you.
Thank you very much, Sean. And this is another beautiful example of how the community can take the matter into your hand and work alongside with the government to make sure that you get the service that are not only essential but vital to you, right? Dialysis is such a life or death for the people with the kidneys problem, kidney function problem. So congratulations, Kenya, for being able to have 200 dialysis units in the country and make it available. And you also mentioned other challenges, but it's seeing that how you engage with the government, how you mobilize your community to push this issue. I believe that that's the best that you could have achieved already, and hope that other countries can do the same thing. The patient association can get so organized and achieve that. You already mentioned the issue of COVID-19 and vaccine for the people with NCD challenge, and I think that would be a next priority for universal health coverage and global health. But thank you, John, for very inspiring experience. And our next speaker, let me invite Dr. Laurel Sprague, the Special Advisor on Community Mobilization, Gender and Human Rights and Community Department of UNAIDS. So we have heard from the government, from the people, the community people, from the patient perspective. And now we will hear from Laurel from the UN organization. Lawrence is going to share reflection on the country level conversation fitting to the State of UHC Commitment Review, the voluntary national review process, the in-country SDG progress review for health, and other accountability-focused processes. Lauren, please.
Thank you, Juan. Good afternoon, everyone from Geneva. I really want to thank the NCD Alliance for organizing this important event. There's a lot we can learn from the excellent speakers that we've heard so far. On behalf of UNAIDS, I want to say how pleased we are to be part of this as a co-host, and also how honored I am to be a speaker with you today. So as I'm sure listeners are aware, the HIV response since its very beginning has been a community-driven and community-led movement, often by necessity. We know that where there is social participation and engagement of those left behind for HIV-related services, we see better outcomes for people, reduced new infections, reduced deaths, and better health with lifelong treatment. Over the decades of the HIV response, we have learned that civil society and community can do so much, and particularly people living with and affected by HIV, who are part of the solution, not just service recipients. That communities are implementers, planners, monitors, researchers, and rights defenders. And this is all the more true for those who are left behind, who are excluded and underserved. In HIV, as well as many other diseases, these are those who are disadvantaged in socioeconomic status or marginalized, like adolescent girls and young women in Africa, and also in countries all around the world, and people who are criminalized, stigmatized, and discriminated against, including specifically in HIV, sex workers, gay men and other men who have sex with men, transgender people, and people who use drugs. So we do have, after these years of work on HIV, very strong evidence that shows that community-led responses help to change these elements so that services can be tailored to the needs of those who are left behind. I believe the same challenges apply to people living with NCDs, disability, and mental illness. And let's also remember that in many cases, we're talking about the same people. These are not distinct and different groups. If we put people at the center of all of our approaches, their social participation and engagement allow us to meet the call of the political declaration of UHC from the HLM in 2019 to reach the furthest behind first. UNAIDS was honored to have been in partnership with the CSEM, IFRC, and Save the Children in the CSEM-led civil society consultations on UHC prior to the high-level meeting in 2019. There were some important messages that came from those consultations that I think should be shared here. First, the consultations provided important platforms for civil society and communities to have dialogues between other partners and the government. And this improved the profile of communities in the high-level meeting, in the outcome documents, and UHC implementation. The top advocacy asks from civil society and communities consistently focused on improving the accountability framework on UHC, as well as calling on governments to recognize and support the role of civil society organizations and communities in health to replicate the best of what is happening in the HIV response. The CSEM-NCD Alliance, IFRC, Save the Children, and UNAIDS are again continuing this partnership for the preparation of this year's UHC commitment report. This will allow us to focus on what is working, what populations are most left behind, and what are the challenges these populations face in accessing quality healthcare. We're looking at what are the critical UHC gaps in countries. As the social participation movement for health and development progresses, there could be opportunities that we can further utilize, including building firmer linkages with the SDG movement, which governments around the world have all committed to, including SDG 3, of which I think people are aware, UHC is a major part. This will allow us all to maintain our focus on the reality that health is never a standalone effort, but an all of government and all of society effort. Working on together with governments and communities on voluntary national review processes provides an ideal opportunity for our work to set up these linkages with the SDG movement. In closing, I want to say that UNAIDS, as the co-lead in the Global Action Plan for SDG 3, is committed to continue to advocate and provide support to communities and civil society to be empowered and supported for improved social participation, to be able to play their role in the move towards universal health coverage. And I thank you.
Thank you very much, Lawrence, for your very concise and right to the point intervention. I think we all know that the HIV movement has been like always a shining example of the community movement of the people who are most affected by that health issue to get organized, to advocate, and to make the service happen to them, to change the policy in the way that support their life and not just treat them as a patient, but as a empower member of the society. And I think for the process of developing the State of UHC Commitment Report, UNAIDS has been working alongside with the Red Cross, with CSEM and others to organize the consultation, country consultation in the same manner of the community being in charge of the issue of their health, and the people who are most marginalized, who are most left behind, have opportunity to speak and get their perspective recognized. So thank you, Lauren. I let now move to our next speaker, our dear friends and colleagues, Dr. Justin Koonin. Dr. Justin Koonin is now the co-chair of UHC 2030. That's the global platform, a multi-stakeholder platform on global health, and to ensure that we achieve UHC, universal health coverage, by 2030. Justin also the president of ACON, an LGBT organization in Australia. Justin, over to you.
You are currently
Justin,
muted.
you need to unmute. Yeah.
You'd think we'd be used to this by now, but clearly not. It's an honor to be here. Thank you, Juan, and all the organizers, and also an honor to follow Laurel, who's doing a really terrific job coordinating with civil society on the high-level meeting, which is in a mere 3 weeks' time. So thank you. And I think we're actually at an extraordinary moment in global health, because COVID-19 has exposed all the inequities that prevent us achieving health for all. It's like water has seeped into all the cracks that divide us in our societies and expanded them. And so the marginalized have become more marginalized, the vulnerable more vulnerable. That's the one side. And at the same time, the pandemic has really focused the world's attention on health. And given all countries the opportunity to rebuild health systems differently. And this gives us a tremendous opportunity as we move forward. So let's think first about the big picture around the COVID response and how that connects to what follows, about what countries need to do next. And then I'll say something specific about the role of communities and civil society and community-led responses. And so right now, I think we, the world, in whatever sector we come from, need to do three things. And the first is to ensure equitable access to COVID tools around the world. And to do that, we need to fully fund the Access to COVID Tools Accelerator, ACT-A, and to adequately prioritize health systems within it. You probably know that ACT-A has three separate pillars working on diagnostics, treatment, and vaccines. And then there's this so-called health system connector, whose rationale is that vaccines only get into people's arms if there are functioning supply chains and storage, health facilities, well-trained health workers, and effective inclusion of communities critical to us, and so on. And we've seen in many parts of the world that where those things are not there, even if vaccines are available, they don't get into people's arms. And so there's a real opportunity in the course of delivering a solution to the COVID-19 pandemic to strengthen health systems in preparation for future health challenges. And I have to say that to some extent that opportunity is being missed. The health system connector is by far the least funded of the ACT-A pillars, and that needs to change. So that's the first thing. Second, I think we need to focus on emergency preparedness. There's a really important report of the Independent Panel for Pandemic Preparedness and Response, which has just been released. And we really need to make, and this hopefully is now obvious to most people, pandemic preparedness a top international and national priority. But importantly, it needs to be aligned with overall efforts to build resilient and equitable and accessible health systems, not as it looks like in some places as some separate silo. Pandemic preparedness is really the step zero of universal health coverage, not something which stands outside of it. And so that brings me to my third priority, which is around action on universal health coverage commitments, which are now more important than they ever have been. It's been abundantly clear that countries with strong health systems have been far more prepared to deal with the pandemic and to deal with the secondary impact of the pandemic on other dimensions of health. And to those that have made comments in the chat box around this, it's very clear that UHC must include the full spectrum of health interventions: prevention, promotion, treatment, rehabilitation, and, as you've all pointed out, palliation. We had in 2019, in the political declaration on UHC, the most ambitious and comprehensive declaration on health in history. And it's time for countries to make good on the commitments they made back in 2019. And so bringing these three priorities back to communities are really at the heart of each one of them. We need to fully fund community-led responses within the ACT Accelerator and the Health Systems Connector. The IPPR report makes it clear that national responses have been far more effective when there's coordination with and involvement of community leaders and community health workers. And universal health coverage is nothing more than a slogan if we don't place those furthest behind at the center. And the only way you do that is through community participation. And the key to all of this, I think, is institutionalization. It's really difficult to create these structures for social participation in the middle of a crisis. It's far better to prepare them in advance and to develop trust between community, civil society, and government in advance. And there are best practice examples out there, like Thailand's National Health Assembly, like Tunisia's Societal Dialogue for Health, and the États généraux de la bioéthique in France. And so these are the lessons that we've tried to distill in the Handbook on Social Participation for UHC, which Eliana mentioned in her introduction. And I really hope you'll join us at the launch, and hopefully we can post in the chat box the link for registration for that launch. So I'll stop there, and we'll be really keen to have a discussion in the next section. Thank you very much.
Thank you very much, Justin. And I think, as Justin had pointed out, universal health coverage will only be a slogan without the participation of the society, of the community, of the people who left furthest behind. And I think Justin also pointed out that universal health coverage is the whole range of health, from health promotion to prevention to treatment to palliative care. So palliative care, and I'm so impressed and happy and pleased to see so many colleagues from the palliative care working on palliative care to make your message across. So there is activism, there is mobilization. So thank you, palliative care community, to raise your voice, and I hope that we continue this way so that no one is left behind, but also no health issue, no important health issue is left behind. So thank you very much for that. And please note in the chat box is a link to the handbook for social participation launch. There'll be a launch of the handbook, and hope you can get opportunity to participate. So we have a few minutes left for discussion, and I would invite to I see a question for John, so I will ask John to respond to the question before we come to the intervention of the participant. There's a raise hand function, so if any of you who want to make an intervention, please raise your hand. We will invite you to speak. So John, the question for you is from Dr. Das, is that how your organization is dealing with issues related to kidney transplantation, such as medicine, reagent, manpower, and complication. John, if you can respond to 1 or 2 minutes, that would be great. John.
Thank you. Thank you very much. I think I can't start my video, but I can be heard.
Yes,
yeah,
we can hear you.
Please go ahead. Yeah, we can hear you.
Okay. If I got the question correctly, is how our organization is responding to challenges of medication for kidney patients who have had a transplant. It's a big challenge for patients who have had a transplant, because after transplant, a transplanted patient needs to take medication for life. That is to prevent the transplanted kidney from being rejected by the body's immune system. So the medication we take is to suppress the immune system so that it does not reject the new kidney. Now, this is medication that one must take every day for the rest of their lives. And usually it becomes the most expensive item on any patient's menu of things that they need to take every day. And we have been urging the government, we've sent petitions, we have canvassed for the government to include post-transplant medication in the National Hospital Insurance cover. We already have a cover for patients who are on dialysis. The health insurance, the National Health Insurance also have a cover for the transplant itself, the operation. And what they are not covering at the moment is the post-transplant medication. And we are in discussions both with the doctors and the National Health Insurance itself to bring this across so that now all the patients, whether they are on dialysis or transplanted, are covered with medication. On our side, as a patient group, what we are doing is we do try to support one another where we can. We scout for the places where we can get medicine at the fairest of prices. Sometimes we fundraise, and we've done a lot of fundraising during the COVID era, because like I said earlier, a person who is whose immunity is compromised is at a higher risk of getting COVID-19. So when we were instructed and advised to stay at home, most of us went home, we stayed at home, we couldn't work, and therefore getting medicines became a problem. So a lot of us fell into problems and we couldn't get medicines, and we did fundraise amongst ourselves, and we were able to raise some money for buying medications for some of our members who are affected. Also to add that that was actually one of the lowest moments in my activity in this organization, because it is really humbling to go back to the same patients who are suffering and to ask them to still go beyond their pain and suffering and contribute something small for their struggling colleagues. So I would really urge, the government and the authorities to consider that post-transplant medication should be part of the whole kidney package that is being given currently by the National Health Insurance Fund in the country. Other countries have done it, we can do it as well. Thank you.
Yeah. Thank you very much, Sean, for your very detailed response. You are on top of this, absolutely. And I see there are 3 hand raised. I will invite you to, actually one of you to give intervention for, if you can make it in 1 minute, because I see that there are questions for Dr. Pierre as well. Then, so after the intervention from Shamin and Fernanda, I will invite Dr. Pierre to respond to the question. So, Shamin, please come in and share with us your perspective. You need to unmute. Yes, go ahead, Shamin.
Yeah, thank you giving me this opportunity to talk here today. As I'm from Bangladesh, and where health system for providing the services in terms of is not up to that mark, as well as universal health coverage perspective has not get any momentum in our country. So my point is there any initiative can be taken or suggestion for country like Bangladesh or LMIC countries?
Thank you, Shanim. I think, I don't know if it's me who lost you, but I lost part of your question. Can you repeat your question, please?
Yeah, my point is, I'm from a country called Bangladesh, and it is a LMIC countries, and our health system is not prepared to provide any critical services like palliative care. We don't have any structure for palliative care. Even any critical services like non-communicable disease. And if you look at that, universal health coverage perspective is really new here, and our government is not prepared to introduce this thing for our country. And my understanding is that our health system is not prepared for this thing. So do you have any suggestion how we can advocate and response to accommodate this type of universal health coverage within our countries like Bangladesh?
Yeah, thank you very much. So that's the question for the panelists and the participants. So if anybody have any suggestion for Shanim, for Bangladesh, please do put it in the chat. I am afraid that we may not have the time to go for the response. I will try my best, but yeah. But please put in the chat box if you have any suggestion. I think the next speaker, the next person who wants to intervene is Fernanda. Fernanda?
Hi.
Please come in. Yes.
Hi, how are you? And nice to to be with you. I would like to hear if your countries have good examples in how to address the undiagnosed case of cancer and cardiovascular disease, because like here in Brazil, we have seen a lot of cases that are under diagnosis. The number will increase, and we are going to have another pandemic in the next few years.
Yeah. Thank you very much, Fernanda. So we have heard about palliative care. Now we hear about cancer. So the need for is we really need a universal health coverage, right? So it shouldn't be only about communicable disease or non-communicable disease or diagnosis or transplantation, but the full spectrum of all the health issue. So thank you, Fernanda, for raising the point. Now let me go back to Dr. Pierre for and invite Dr. Pierre to respond to question. Do you know the person who's doing your same activities in Togo Ministry of Health? Please let Minon know. Yeah, so Dr. Pierre, do you know your counterpart in Togo?
Please, I didn't understand very well the question. Can you repeat, please, for me?
Do you, if you can look on the chat box, there's a question in French for you. Yeah.
I didn't see.
In the Q&A, sorry, in the Q&A.
Let me look for the question. You can continue, and I will come back.
Okay. So so I think this we will get Dr. Pierre to come back to us in a minute. Justin, do you want to comment on the question from Shanim from Bangladesh?
Sure, I can try. I mean, I think this is a really good question. What do we do if we don't have resources in our country? And that is an issue for many countries around the world. But in the chat box, I pointed to the example of Thailand. When Thailand introduced a system of UHC in the year 2000, maybe 2001, their GDP was not high. I think it was about $1,900 US a year, actually. And so, yes, it's about resources, but it's also about priorities, and it's also about using those resources efficiently. On the other hand, there are countries that have a lot of money, I'm sure they come to mind, that don't have effective systems of UHC. So resources is only one part of the issue. It's actually how they're used. There's a famous quote from the health minister of Thailand, who said we introduced UHC because we were poor, not in spite of the fact we were poor. We couldn't afford not to introduce UHC. So yes, resources are an issue, but I don't think that we should let governments off the hook and say, well, okay, well, there's nothing we can do. There's always something you can do. Thanks for the question.
Yeah, thank you, Justin. And I see that there are some more comments and respond to Bangladesh, to Shanin's question. Now I invite Dr. Pierre back. Dr. Pierre, did you see your question in French? Yeah, please.
Yeah, I saw the question about if I know the same person who are doing the same activity in Togo. I don't know very well, but we are not the same health system organization. But I work with Ministry of Health in Togo 3 years ago with the director of family health planning. And I know that in Togo, we have also a national health insurance. So I cannot tell anything more than I don't know very clear the person who are doing the same activity like I do in Burkina Faso. Thank you.
Yeah, and there's another question for you, actually. The question for you, which is in French. But if you can, since we are running out of time, I would really appreciate Dr. Pierre, if you can respond to the question about the relationship between the Ministry of Health of Burkina Faso and the Health Mutuality, Mutual de Santé insurance. If you can type the response in the chat box, that would be great, Dr. Pierre, because now I have to lead the floor to Kati to wrap up. So Kati is the communication officer of Civil Society Engagement Mechanism for USC 2030. Kati, thank you for doing this hard job.
Thank you, Juan. It has been such a privilege to join this rich conversation here today. As we have heard from our panelists, social participation and especially the critical participation of communities who are often underserved, as we've seen in the chat box, centering issues that are often overlooked. This engagement is the only way that we can create systems that are adequately responsive to the needs and accountable to the people, an essential step in achieving health for all. And we know this today more than ever, as we have heard in these discussions, particularly from the intervention of Mr. John Gikonyo. There are stark inequities in the COVID-19 pandemic and its response within and across countries. And this makes it all the more important that we prioritize equity in every decision. Institutionalizing participatory governance is not only morally sound, but also essential to create strong health systems that adequately and effectively respond to the needs of communities, as Dr. Laurel Sprague noted as a lesson from the HIV response. To leave no one behind, then, we must make sure that everyone is represented on the tables that matter and equipped with the resources and information required to make a difference. We also discussed that in these difficult circumstances and often without formal opportunities, civil society has come together to drive collective action and demand accountability, even when civic space is threatened in many areas across the globe. Like Mr. Farouk Hwedy highlighted, communities continue to come together and empower each other in even the most difficult of circumstances. Lastly, we noted today that there is an undeniable momentum, not only for the political prioritization for health, but also for social participation, as Dr. Justin Koonin described of the many global pushes currently happening in this arena. Across the world, questions of equity, about access to COVID-19 tools, vaccines, information, and about transparency in health-related decisions are prevalent in the public domain, from parliament floors and newsrooms to dinner tables. There's cause for optimism in this context. So thank you for joining us here today to amplify the importance of inclusive governance in each step of achieving UHC. We had the pleasure of hearing from our brilliant moderator, Dr. Juan, who, aside from being a global thought leader in the UHC and HIV spaces, is on the ground championing community-led work that improve health equity in Vietnam. We're proud to have her on the CSIM advisory group. Thank you also to each of our wonderful speakers. We could not have asked for a more insightful panel. This thoughtful selection of panelists and discussion was made possible through the leadership of our co-hosts, especially the NCD Alliance. Thank you so much for being here today and this technical team. Thank you also to Save the Children, the Global Health Council, IFRC, Communities at the Heart of UHC, and UNAIDS. And finally, thank you to all of you for joining us today. We have, of course, run out of time, but as you have heard, there's so much more to discuss. We hope you'll stay engaged in this conversation, both globally and in your countries. If you're in a country engaging in the VNR process this year, we would love to hear from you through a survey in the next few weeks that will also feed into the UHC 2030 State of the UHC multi-stakeholder review that Eliana introduced. Civil society representatives in many countries will be able to expand on these questions through UHC focus groups led by these co-hosts. If you would like to participate or learn more, please email csem@msh.org. As a reminder, the WHO Handbook on Social Participation will be launched on May 31st. Please join us for the launch event. The registration link has been added to the chat box. A recording of today's event will be posted and shared through the CSAM listserv, through NCD Alliance, and through our other event partners. Thank you so much, and see you next time.